All right, let's dive right into this explainer. Today, we're tackling a medical puzzle that absolutely frustrates millions of patients and doctors alike: fibromyalgia. Now, if you or someone you know deals with this condition, you're probably all too aware of the sheer overwhelming number of treatments out there. I mean, from miracle supplements online to heavy-duty prescriptions, the whole landscape is chaotic, it's exhausting, and honestly, it's incredibly hard to navigate. But today, we're going to cut through that noise together. We are looking at a definitive, newly published set of guidelines from the Brazilian Society of Rheumatology. They've essentially built the ultimate tier list of what actually works, what might work, and what you should absolutely for sure avoid. So let's get into it.
But before we hit the actual tier list, I want you to think about a massive paradox. Imagine you have a terrible ache, right? So you reach for a standard over-the-counter painkiller, maybe an ibuprofen. Now for a normal injury, it works like a charm. But for fibromyalgia, you might as well be swallowing a Tic Tac. It is practically useless. Why is it the drugs specifically designed to kill pain completely fail when it comes to this specific chronic pain condition? Well, to understand the treatment, we kind of have to subvert everything we think we know about how pain actually works in the human body.
So here's our roadmap for today. 1. The fibromyalgia puzzle. 2. Grading the evidence. 3. The green light treatments. 4. The unproven and uncertain. 5. The hard nose. And 6. Beyond the prescription pad.
Section 1. The fibromyalgia puzzle. Understanding the glitch.
The big medical term you really need to know here is central sensitization. Think of your body's nervous system like this incredibly advanced security alarm. Usually, it only goes off when there's an actual break-in, like a broken bone or a burn. But in fibromyalgia, there's a dysregulation of the neurotransmitter systems. Basically, the central nervous system's pain alarm glitches out and just gets stuck in the on position. There's no break-in, no localized tissue damage, no active inflammation. The alarm itself is just endlessly ringing, causing widespread chronic pain, severe fatigue, and sleep disturbances. You obviously can't fix a broken alarm system with a bandage, which is exactly why those traditional painkillers totally fail.
Moving to Section 2, Grading the Evidence, the Base Interrogation.
70%. That is the magic number here. To figure out what actually works, the medical detectives at the Brazilian Society of Rheumatology didn't just casually guess. They interrogated the data using this really rigid framework called the BASCE system. They looked at massive systematic reviews, meta-analyses, and then a panel of experts voted. For any drug to earn a recommendation in this guideline, it had to cross a massive threshold, a minimum 70% expert consensus. If it didn't hit 70%, no official seal of approval. This ensures we're only looking at the absolute most robust, undeniable data available.
And we're pulling these facts directly from the official guidelines published in the journal Advances in Rheumatology. So we aren't relying on anecdotal evidence or some random internet forums today. We're breaking down peer-reviewed, vetted, 70% consensus medical science to build out our treatment tier list.
Section 3. The green light treatments, approved and proven.
Okay, get this. What's completely fascinating here are the drug classes that actually pass the test. We don't see standard painkillers on this list. We see antidepressants and anti-epileptics. No way, right? But why? Because these are the drugs that actively alter neurotransmitters. You've got amitriptyline, a tricyclic antidepressant that modifies serotonin and norepinephrine pathways, offering really significant improvements in pain and sleep at low doses. Then there's duloxetine, an SNRI, which hits its absolute sweet spot for symptom relief right around 60 milligrams a day. And finally, pregabalin, an anti-epileptic drug that actually reduces calcium influx into the nerve terminals. This brilliantly helps turn down the volume on all that pain and fatigue.
We've also got a couple of secondary green lights to mention. Cyclobenzaprine is technically a muscle relaxant, but here it's specifically recommended at bedtime because it has a super proven track record of helping fibromyalgia patients achieve way better sleep quality. And then there's milnacipran, which is another SNRI, kind of similar to duloxetine. It's shown solid, moderate pain relief, offering doctors another great tool if the first options aren't tolerated well by the patient.
Section 4. The unproven and uncertain. The yellow light. So these are the treatments stuck in clinical limbo. They are incredibly popular, you hear about them all the time, but when put under the strict microscope of clinical data, they just don't have enough high-quality evidence yet. First up, cannabinoids, medical cannabis. Studies show it's generally safe and might offer some short-term relief, but the data is just weak, and scientists still don't know the optimal THC to CBD ratios. Next is gabapentin. It's widely used in clinics everywhere, but surprisingly, the strict clinical trial evidence for it is actually insufficient to officially recommend it. And finally, low-dose naltrexone, or LDN. It's an incredibly promising concept that aims to reduce central nervous system inflammation, but current trials are pretty small and carry a high risk of bias. The crucial takeaway here is these aren't necessarily bad treatments, they just desperately need way more rigorous testing.
Now, Section 5, the hard nose, the red light.
This is where we need to drop the tone for a second because these are the treatments that outright failed the medical interrogation. When a patient is in pure agony, their expectation is to be given a pill that offers immediate pain relief so they can just function normally. But the actual evidence for fibromyalgia reveals a really harsh reality. Take opioids, for example. Prescribing opioids for this condition doesn't just fail to stop the pain. The data explicitly links opioid use in fibromyalgia patients to worse clinical outcomes, deeper depression, and much more severe insomnia. It actively harms the patient.
So here is the official rejected list. NSAIDs, like ibuprofen or naproxen. Why? Because as we learned, fibromyalgia is non-inflammatory. Using an anti-inflammatory drug on a nervous system glitch is literally like using a fire extinguisher on a computer virus. It makes no sense. Opioids are strongly advised against, as we just covered. Standard SSRI antidepressants, like fluoxetine. Well, they're fine if you're treating comorbid depression, but they totally lack robust evidence for treating the actual physical pain of fibromyalgia. And finally, those dramatic interventions like intravenous lidocaine or ketamine, they simply show no sustained long-term benefits.
Section 6, beyond the prescription pad, the multimodal reality.
If you take literally one thing away from this explainer, it needs to be what the authors of this guideline make incredibly clear. I'm going to read this directly from the study. Pharmacotherapy alone is insufficient. An integrated, multimodal approach is essential for optimal disease management. Medicine alone will not win this battle. The pills are just one piece of the giant puzzle.
To actually combat fibromyalgia, you need a coordinated strategy. Step 1 is the evidence-based pharmacotherapy we just discussed, right? Finding the right green light medication to turn the volume of that alarm down just enough. But step 2 is physical activity. Step 3 is patient education, truly understanding your own body's limits. And step 4 involves psychosocial interventions, like cognitive behavioral therapy, to help manage the immense mental toll of chronic pain. Those green light pills, they only truly unlock their potential when you combine them with movement and mental health care.
Now, science is obviously never static, right? It's always evolving, and it's exciting to think about where this goes next. These guidelines represent the most rigorous, up-to-date snapshot of what we know right now, synthesized by top experts. But researchers are constantly testing new molecules, exploring entirely new pathways, and running much larger trials on those yellow light treatments we discussed earlier. The understanding of this disease is moving fast.
We've seen how targeted antidepressants and antiepileptics can begin to quiet a glitching nervous system. We've seen that standard painkillers are effectively a dead end. But all of this leaves us with a pretty fascinating, open-ended question for the future of medicine. If the human body's internal alarm system can be accidentally rewired to stay on, what exactly is the next frontier in permanently turning it off? Thanks for joining me on this explainer today, and always keep questioning the science.